Now we're getting to the nociception or pain detecting or damage detecting system of the central somatosensory system. So nociception is important for limiting tissue damage and deciding what our reaction to pain is going to be. All of our different somatosensation that comes in is perceived as pain if it has the potential for tissue damage or if the brain assesses that it has the potential for tissue damage. In chapter 12, we're going to talk about pain as disease and the dysfunction of the nociceptive systems. But in this last section of chapter 11, we're going to talk about the function rather than the dysfunction. So we're going to talk about referred pain and primary hyperalgesia. In chapter 12, we'll talk about secondary hyperalgesia and a couple other different pain symptom terminology points. We're going to talk about the pain matrix and what it is, and the characteristics of acute pain versus chronic pain. And we're also going to compare nociceptive pain to neuropathic chronic pain and the 5-level model of anti-nociception. So anti-nociception is our body's pain control systems. And there's 5-level model that's presented. So pain in the clinic is frequently associated with tissue damage or potential tissue damage. Although pain can be experienced independently of tissue damage. If your brain decides like, okay, I need to I need to send some pain signals somewhere. Nociceptors signal injury. Persistent pain affects emotional and autonomic function and affects your social life. If pain is taking over your life, then that's not a good place to be. Signals interpreted as both fast and slow pain can occur with musculoskeletal injuries. When a tissue is injured or ischemic, deprived of oxygen, biochemicals that awaken nociceptors are released. Nociceptors that are excessively reactive to stimuli are called, when nociceptors are excessively reactive to stimuli, it's called peripheral sensitization. And we also have central sensitization. So sensitized neurons can fire in response to normally innocuous stimuli with slight movements and spontaneously. So the example that I give of this is when you get sensitized neurons that fire in response to normally innocuous stimuli. Normally, when you take a warm shower, it feels good, warm water running on your skin. But say that you got a sunburn and now your neurons are sensitized because you had some tissue damage. And now you get in like a cool to warm shower and it feels painful instead of it feeling good. So a normally innocuous stimuli like nice warm water now is painful, or slight movement can be painful, or you can just get pain spontaneously if your neurons are sensitized. So unlike superficial pain, deep pain usually occurs after tissue has been damaged. So the function of deep pain may be, I mean, nobody really knows, but it may be to encourage rest of the damaged tissue. It's like, okay, this hurts, you've got to stop and rest it. After a lower extremity injury, pain with weight bearing often produces a modified gait. An antalgic gait is what we call it. It's characterized by a shortened stance phase on the affected side. And in layman's terms, we call it limping. In therapy terms, we call it an antalgic gait. But you can identify that. Probably any one of us could just go out on the street and watch people walking and go, oh, that person's left leg is hurting or something like that. So that the deep pain and the modified gait is really sort of trying to get your body not to put as much pressure on the damaged area. Referred pain is pain that's perceived as coming from a site distinct from the actual site of origin. So referred pain, it clinically is usually pain referred from visceral tissues to the skin. So it's like you're having a heart attack, but you have left arm pain, or you're having gallbladder attack and you have mid back pain or scapular pain. So the explanation for referred pain comes from the convergence and facilitation of nociceptive information from different sources. So we're getting different sources bringing information into the spinal cord, and sometimes they're going to facilitate each other, sometimes they're going to inhibit each other, and that those our visceral tissues don't really have the same sensation as our somatic tissues. And so the referred pain is a way of getting our attention, basically, if you want to think of it that way. Like, hey, gallbladder here, something's going on, it hurts, and it refers it to. There are specific pain referral patterns. This is the diagram from the book. Different organs refer to specific different cutaneous areas. And that's because of their neural connections in the spinal cord. The pain matrix consists of brain structures that process and regulate pain information. So the pain matrix responds to pain, like actual nociceptive input, but the pain matrix is also capable of creating pain perception in the absence of nociceptive input. So it includes parts of the brainstem, the amygdala, which is a big part of the limbic system, hypothalamus, thalamus, and areas of the cerebral cortex. So they're all kind of working together to process information about pain and decide what we're going to do. And so the pain matrix can just decide, well, she needs some pain, even though she's not getting any nociceptive input for whatever reason. It can be because of nervous system pathology, but there are other reasons as well. So the experience of pain is strongly linked to emotional, behavioral, and cognitive phenomenon. We all know that. Understanding requires the consideration of discriminative, motivational, affective, and cognitive evaluative components. Discriminative aspect refers to the ability to locate the site, timing, and intensity of tissue damage or potential tissue damage. So there's a lot that goes into pain, and pain perception and the reaction to pain can also be cultural. There are cultures where it's considered not cool to show that you're in pain, and other cultures where it is very acceptable to show that you're in pain. So it's really complicated. It's not a simple thing, for sure. The motivational affective aspect of pain refers to the effects of the pain experience on emotions and behavior, including increased neural arousal and avoidance behavior. So that's the not being able to sleep at night or not wanting to do, like, I don't even want to try putting weight on my foot because I know it's going to hurt. The cognitive evaluative aspect refers to the meaning that that person ascribes to pain. So some people, any type of pain is the worst pain ever for them. And some people just say, well, I don't care how much it hurts, I'm going to walk it off or whatever. However you take it that way. The other thing too is it's actually been shown in several different studies. The more you can educate people about the physiological and neurological aspects of pain, the more they know about it, the less meaning they ascribe to the pain, and so the less pain they will have. Very interesting. It's called therapeutic neuroscience education, and it does work. So the typical response to some source of pain, so the example in the book is hitting your thumb with a hammer. Ah. So you withdraw the thumb, you yell, maybe you apply pressure. So the first scientific explanation of how pressure and other external stimuli inhibit pain transmission was the gate theory, which we've talked about. That was first theorized in 1965. Some of the details that Melzack and Wall first came up with have turned out to not really pan out. But the original theory inspired inquiry into the mechanics and control of pain, such as TENS. So TENS uses the electrical current applied to the skin to interfere with the transmission of nociceptive information at the dorsal horn of the spinal cord with inhibitory interneurons. So the there are certain pain responses that we automatically do. Your arm hurts, you're going to hold it at your side. You slam your finger in the door, you're going to put some pressure on it. And so we're applying that mechanical force to hopefully stimulate some A beta neurons to gate the pain at the spinal cord. The counter irritant theory incorporates finding from research that was stimulated by gate theory. And the counter irritant theory explains the inhibition of nociceptive signals by stimulation of non-nociceptive receptors in the dorsal horn of the spinal cord. So it affects pain transmission, like we talked about. So gate theory is like the original thought, and counter irritant theory is what came out of it. And we'll talk about the 5-level anti-nociception schema, and this is level 2 in that 5-level schema. So anti-nociception is the suppression of pain in response to stimulation that would normally be painful. Endorphins are endogenous substances that activate anti-nociceptive mechanisms. Opiate receptors are the receptor sites that bind with both endorphins, endogenous opiates, and exogenous ones that we get from an external source. So this is our 5-level theory of anti-nociception. And so anti-nociception can happen at different sites. In level 1, so all of these are levels at which pain can be modified. So the transmission of nociceptive information can be altered at several locations in the nervous system. The 5-level model includes the periphery. So level 1 occurs in the periphery, where endogenous opioids can bind to receptors on peripheral afferents to limit nociceptive transmission. It can also be over-the-counter NSAIDs like aspirin and ibuprofen, which get rid of prostaglandins and other irritating chemicals in the periphery that sensitize nerve endings. So level 1, it occurs in the periphery. That's the main thing to know. Level 2 is in the dorsal horn, so altering pain transmission in the dorsal horn. So the release of enkephalins, dynorphins, or GABA, was gamma aminobutyric acid, which is, remember, it's one of the main inhibitory neurotransmitters in the central nervous system. The release of those chemicals by inhibitory interneurons limits the transmission of incoming nociceptive signals. So this is the level of the dorsal horn that gating mechanisms work on. The activity in that second order neuron is altered by release of different chemicals. So serotonin can also be involved, and norepinephrine, to modify transmission of nociceptive information in the dorsal horn. So there's a lot more going on than just gating, but that's where level 2 occurs. Level 3 is called the fast-acting neuronal descending system, which involves some areas in the brainstem and the diencephalon. Activation of those areas may occur due to descending cortical input or the binding of endogenous opioids to their receptors. So basically, level 1 is considered ascending control. Level 2 is considered ascending control. Level 3 is descending control. Level 4 is the hormonal system, which involves some areas in the hypothalamus and the pituitary gland and the adrenal medulla. This is thought to be the level that low rate TENS works on, but it's not 100% proven. Level 5 is at the amygdala and cerebral cortex level. So the amygdala contributes to emotional aspects of pain, including anxiety. And the cortical level, expectations, excitement, distraction, and placebo all play a role in adjusting the transmission of nociceptive signals. So distraction using virtual reality has been tried, and it's been shown to decrease the ratings of pain in people who are getting like painful procedures like wound debridement or treatment of burns, that sort of thing. So that placebo anti-nociception can also be effective, um, and it gives the same effects as like exogenous opioid treatment, just by using the same mechanisms in the brain and using endogenous opioids. So it's pretty interesting. You can have descending or ascending control. There are lots of different natural systems in our body that control pain, and then we have the some of our things, the treatments that we can do that affect that. So pronoceception is the biological amplification of nociception. So pain transmission can be intensified at several levels. So we said we can, anti-nociception can happen at several levels. Pro-nociception can also happen at several levels. So edema and endogenous chemicals can sensitize free nerve endings in the periphery, increasing pain. Pro-nociception may occur when a patient is anxious or depressed. So your brain just says, whatever, I'm gonna, I'm gonna amplify pain, which, that's kind of a drag. So, nociceptive chronic pain is where you have chronic pain due to continuing stimulation of nociceptive receptors. So the example is from like a tumor pressing on nociceptors, that's continually stimulating those nociceptives. So the neurons are functioning normally, um, and chemical changes in the damaged tissue can awaken sleeping peripheral nociceptors. So neurons that fire together, wire together, is the way they say it. So if you keep, like we talked about in the neuroplasticity chapter, if you keep stimulating certain pathways, they're going to go, oh, she wants to use these pathways. I'm going to keep doing it. So pathways that you use more are going to get reinforced. So primary hyperalgesia is excessive sensitivity to stimuli in injured tissue. So that's like I was talking about the taking a shower when you're sunburned. You have hyperalgesia. Your nerves are sensitized, and so something's more painful than it would have been if you weren't injured to begin with. Nociceptive chronic pain serves a useful biological function as a warning to protect the injured tissue. So it's a normal response of our nervous system.